Again, as it was said, I'm Stephanie Blank. My teal, I don't know if you can see it. It's my this scarf. I don't have the wonderful outfits that you guys have. It's always hard to find teal outfits. Anyway, I'm speaking this morning on something pretty exciting: the evolving role of PARPs and ADCs in overcoming ovarian cancer. I'm coming to you live from New York. It's not raining here, but it's really, really cold. Here we go. These are my disclosures, and some of what I will be discussing is investigational. So I was asked to speak on the evolving roles of PARPs and ADCs in overcoming ovarian cancer, and this was Brunsey's title, which I thought was quite cute. Now, PARPs are PARP inhibitors and antibody drug conjugates. ADCs are antibody drug conjugates, and to me, this is actually kind of two separate talks. So let's just begin with this first part of the talk. That's the only fancy thing I have in the entire talk. Anyway, so we're talking about background, recent updates, and what they mean. All right, so PARP inhibitors, I'm going to go back a second because I sort of started assuming everyone knows what they are. But what they are targeted therapies for ovarian cancer, and they really represented a huge breakthrough in the field. So between 2014 and May 2020, there were 9 FDA approvals in PARP inhibitors used in ovarian cancer, and they have changed the treatment paradigm in ovarian cancer. I'm looking to the side now. Sorry, can't fix that. Anyway, what they are is they are targeted drugs that interfere with the way that that cells repair DNA, and instead of previously a lot of the ways we treat cancer is basically killing cells fairly indeterminately. Basically, we kill the drugs that grow the fastest, but these are a little bit more specific because they mess with drugs that have in their mechanisms of functioning. So these were really different ways of treating cancer. So maintenance frontline PARP inhibitors, and that's not the only way that we use them, but maintenance frontline PARP inhibitors achieve long-term remission in women with newly diagnosed ovarian cancer and a BRCA mutation, and also offered a potential for cure. However, since May 2022 to present, there have been withdrawals of PARP inhibitors and restriction to prior approvals. So even though we're talking about overcoming ovarian cancer, but I think it's also important to discuss advances and things that we have learned along the way. And that's what this first part of the discussion that we're going to have is. So first, I'm going to discuss the exciting parts of PARP inhibitors. And this is not the beginning of the story, but this is sort of the exciting part of the story. And a lot of when we talk about PARP inhibitors, a lot of what we talk about occurred in people with BRCA mutations. But it's not only about BRCA mutations, but the first things I'm going to talk about are in people with BRCA mutations. So SOLO-1 was a trial where PARP inhibitors were used in patients that have BRCA1 and 2 mutations after they finished their chemotherapy at the beginning of their treatment for ovarian cancer. And they took those pills for 2 years. And what these lines here are is showing how long they went before any disease came back. And when these results were shown, this is before COVID, and people kept using the word unprecedented, which then was like an unusual word to use. So it was used a lot because the way that this was going out a really long time, and these curves stayed really far apart. And what that means is it's a really big benefit. So up to, this was going out at least, 5 years, they never met. And the important thing here that was different from things that we had seen before is the treatment would stop here after 2 years, and still they would stay apart. Now, after that, these lines are basically looking at what's called overall survival. This is how long people are living. And this is going as long as 7 years. And still, we haven't even reached the point at which half of people are no longer alive. And if you think about cancer, people used to talk about 5-year survival. We're way past that here now. We're way past. And again, these lines are flat. And that means that that's when we start thinking about, potential. I mean, I don't want to overpromise, but we're thinking about potential cure. And even though these results are best in people with BRCA1 and 2 mutations. We also have good results in people that have a type of changes in their cells called homologous recombination deficiency, which means that their cells aren't perfect at DNA repair also. But we also see some response in people that have what's called homologous recombination proficient cells, which means that their cells do know how to repair DNA, which means that we can't always predict exactly who is going to respond to these drugs, and that's when they're used up front. So that's an important thing to know. So basically, these drugs have been pretty exciting when used in the front line. So I wanted to just go back a second and talk a little bit about PARP inhibitors, when we would use them and which ones they are. So basically, there's 3 settings in which we can use PARP inhibitors. We can use them in the frontline maintenance. That means when you finish your chemo at the beginning of your treatment for ovarian cancer, you can use them at the very beginning, right after that, to sort of maintain that response. Platinum-sensitive recurrence maintenance means that you get some chemotherapy if your cancer comes back long enough after prior treatment, and then you go on maintenance after that. And then there's also an instance in which you would use it for treatment by itself, and that would usually be pretty far down the line. And then there are 3 FDA PARP inhibitors, and they're called niraparib, olaparib, and rucaparib. Sometimes when I say the names of these drugs in the clinic, my patients just look at me like I'm crazy, but I'm going to be saying them a lot, so I apologize for that. So now we're going to talk about when and for whom. So again, we talked about frontline maintenance, platinum-sensitive recurrence maintenance, and treatment. So we have 3 groups of patients. I spoke about them a little bit before. I really tried to make this simple. I know it's not simple, but bear with me. Sharon, I hope you will also just cut me off if I run over, since I had all those snafus. I would prefer you cut me off than I mess up everybody else's day. Okay, please just cut me off, okay? So we have patients that have BRCA1 and 2 mutations. Those are genetic or tumor mutations. Then we have those that have homologous recombination deficiencies. Those are with the issues with the DNA repair, and then homologous recombination proficient. So we have those in frontline, recurrence, and for treatment, we would, the only patients that were ever approved to use those for treatment were either those with BRCA1 and 2 mutations or homologous recombination deficiency. So let's start with treatment. We had these 2 groups. So and sometimes we call treatment monotherapy. So this was only used for recurrent ovarian cancer, and it was only ever used 3rd line or later. So these are the approvals. Olaparib was used for people with germline mutations, recurrent ovarian cancer. Rucaparib was either it was either in germline or in the tumor, and niraparib was used for homologous recombination deficiency. These were when the approvals were. But then there were some withdrawals, and these all occurred in 2022. Both rucaparib and olaparib, they had release of some study data. Previously, they had been approved based on what's called progression-free survival, looking at how long it had gone. Those drugs had kept the ovarian cancer from coming back. But when they eventually had overall survival data, it did look like that the overall survival data, they favored chemo. They had been compared with chemotherapy. And for that reason, the FDA strongly suggested that these be withdrawn. So those 2 were withdrawn. And then niraparib also was withdrawn based on the others' data. So again, the original approvals had been based on progression-free survival data, but when overall survival data came back, it favored chemo. And it's not uncommon for approvals to happen based on progression-free survival, because overall survival data takes a lot longer. And there are a lot of issues here because there's crossover. And I don't want to get into all that. There's a lot of issues here, but this is what happened with that. So we no longer have it being used for treatment. Then we have this platinum-sensitive recurrence maintenance. So then we have those with BRCA1 and 2 mutations and BRCA wild type. So we don't separate it out for the HRD. So then we had these approvals basically for all groups for all of the different PARP inhibitors, and it was used it could be used at any point down the line. But there were then the same type of thing happened where for niraparib and rucaparib, these became restricted, and for the same type of thing. They had originally been approved based on progression-free survival data, and then what happened was they got the overall survival data back, and then they were restricted. Of note, for niraparib, they were restricted only to germline mutation patients that had germline mutations. For rucaparib, they could have either germline or tumor mutations. Olaparib stayed the same. Their data did not look exactly the same as the others. So what we ended up having is for frontline maintenance, everything is just the same. There's no problem there. For platinum-sensitive recurrence maintenance, if you have a BRCA1 or 2 mutation, everything is good. For BRCA, this got confusing with my animation. I so apologize. Let me put it all out there. For platinum-sensitive recurrence maintenance for BRCA wild type, it's a really it's a mixed bag, because for some of them, if you're on olaparib, it's okay, but the others is not. And for treatment, for all of it, it's all withdrawn. So what does this mean? What does this really mean? So especially for patients with BRCA mutations or HRD tumors, strongly consider PARP inhibitors in the upfront maintenance setting. And this may be true for those who have neither of these as well. I think if you're early in your ovarian cancer treatment experience, it's definitely worth discussing PARP inhibitors with your physician. If you're already on a PARP inhibitor, I would not panic at all. I would really speak with your physician, and this just really shows that we're always learning. So let's move on to the second part of our talk, and that is antibody drug conjugates. And so for this part, I want to speak about what is an ADC. I want to speak about the specific ADC, mirvetuximab, and I want to speak about what is on the horizon for ADCs. So this on the right is a picture of an ADC, and an ADC has 3 parts. So it's made up first of a monoclonal antibody, and that is a protein that seeks out a specific target on cells. And then there's a linker, and that the linker links the two kind of more operational parts of the ADC. But and this actually, even though it sounds like just like glue or something like that, it actually has a lot of important chemical structures, because it attaches the drug to the antibody, and then once it gets inside the cell, it knows to release the drug. And then we have the cytotoxic payload, and that's the drug designed to kill cancer cells once it gets into the cell. And so this is how they work. So the ADC binds to the target antigen on the cancer cell, and then it's sort of eaten up. This looks like a little Pac-Man, but it really is, it's eaten in there. And then once it gets in there, the ADC is degraded and the payload is released. And then it exerts its effect. Most of these are usually, they're usually, their effect is usually in the DNA or in the what's called the microtubules. Those are part of what works in the DNA, as that is a part of the replication of the DNA. And when you disrupt them, it leads to cell death. And then the other interesting thing about ADCs, a lot of them have this effect that's called the bystander effect. I mean, you've heard about that with other things, but basically, once one cell is affected, even if a nearby cell doesn't have the receptor on it, it can hit it and affect it. So it's almost like, I think it's like a pinball machine or something like that. I say ping pong ball, but that's not the right analogy. It's something, it's like 2 balls hitting each other and they all affect each other. So what's exciting about this is that, oh, I put it on the next slide, I think, the exact time, but within the past 2 years, the FDA granted accelerated approval for mirvetuximab for, I don't say those next 2 parts of the word, for folate receptor alpha positive, I'll explain what that means, platinum-resistant epithelial ovarian fallopian tube or primary peritoneal cancers. To explain a little bit what mirvetuximab is, the trade name is listed there, and it's used in ovarian cancer. This is very similar to the last picture I showed you, but this is now specific for mirvetuximab. So our antibody part, that's what we discussed first, is anti-folate receptor. Our cleavable linker is still a cleavable linker. We're not going to go into the chemistry of that. And our payload is called DM4. So folate receptor is a protein that binds to and transports folate into the cell, and it's expressed on 90% of ovarian cancer cells, and it's highly expressed in 35% of ovarian cancer cells. And our cytotoxic payload, DM4, is a tubulin inhibitor. Remember, tubulin is part of what goes into when cells want to reproduce. So folate receptor alpha is a B vitamin. It plays a role in metabolism, and it's lipophilic. It requires active transport into cells. It needs to be eaten up. And folate receptor alpha is a receptor on cells that assists with folate transport into cells. I guess that's kind of self-evident by the name. It's limited on normal cells, but conveniently upregulated in cancer. Now, DM4, everyone draws a picture of a Trojan horse when they're talking about ADCs in some way, shape, or form. It's really potent. So only a very small amount drives a huge effect. And whenever people talk about this stuff, they use a lot of war-related metaphors. I never like that when we're talking about cancer, but here, that's all I've ever seen. But when they talk about ADCs in general, they use a term called a DAR, which is drug antibody ratio. So basically what that means is how much, if you have a higher DAR, you're delivering a lot more of your payload with one antibody. So anyway, these are very effective that way. They give you that, they end up giving you a lot more bang for your buck, if you will. So again, mirvetuximab, the antibody, this is how they work. The antibody part binds to the surface of the cell. It's eaten up. This is endocytosis. It's degraded. It disrupts. This is the tubulin. It disrupts it, and then it kills it, and then it goes on to help with the bystander effect, killing other cells. So this was FDA approved in November 2022. This is a very convenient time. Remember, 2022 is when they're pulling things off from the PARP inhibitors. Well, guess what? We have something else new happening, and that's sort of like a theme if you want to think about it in a lot of our ovarian or a lot of cancer treatment in general, but we have a lot going on in ovarian cancer specifically. We're always finding new things. That's the exciting part here. So mirvetuximab was approved in November 2022. It's the first novel treatment to demonstrate overall survival benefit in a phase 3 trial in platinum-resistant ovarian cancer. It demonstrated a statistically significant and clinically meaningful improvement in PFS, overall response rate. PFS is progression-free survival, overall response rate, and overall survival compared to chemotherapy. The first ADC for ovarian cancer, the only FDA-approved biomarker-directed therapy for platinum-resistant ovarian cancer, and a new standard of care. Really exciting. I'm going to kind of breeze over the things that I think are a little bit more mundane. I think these slides will probably be available to you. I just missed out on some things. There's testing that you can do. Very importantly, the testing is on tissue. It can be on old tissue. You can get the testing done while you're on some other treatments. And so you can ask your doctor to do that even when you're not actively considering the treatment. You need high expression to be on this specific drug. However, some of the other ADCs that go for folate receptor alpha do not need high expression. This is what a positive result looks like. There are eye toxicities. This would be an issue for me because you cannot wear contact lenses. You need to see an eye doctor a lot while you're on mirvetuximab, and you need to be on eye drops. Here's the exciting thing. These look like Legos, don't they? There are so many different ADCs. There are a lot of different antibodies. There are a lot of different, bang for the, there's a lot of different, each of their parts, there's a lot of different ones. So there's a lot going on here. Some of the most interesting ones, these are ones that have the same antibody, different payloads. These are both being studied. Again, these might allow us to work with people with lower rates of folate receptor. This is a very exciting one. This one is called Enhertu. That's the trade name. Probably not supposed to use it. This is very exciting results in ovarian cancer. This was the most exciting thing, I think, from the recent SGO meeting. I'm 10 seconds over. Using this specific drug, we'll call it RDXD. Every patient, no patient's cancer grew. This is going to be looked at in a phase 3 trial. Lots of ADCs are being looked at in cancer. One more point, broken record. You've never met me before, but I'm going to sound like a broken record to myself because I'm always telling people about clinical trials being the key to advancing science. Clinical trial participation is associated with improved survival in patients with platinum-resistant ovarian cancer. None of these advances could have been made without clinical trials. So I just want to thank every one of you that's ever been on a clinical trial. And clinical trials move us forward. None of these things that we could have even said 3 years ago. So this is truly exciting. Clinical trials have lots of benefits. This is the golden age of advances in ovarian cancer. And I hope you got something out of this presentation. Sorry for going over and the technical difficulties. Thank you.